Hello, my name is Candlin Fogg. Today I will be discussing the risks, behaviors, and treatment options associated with eating disorders among adolescents. First, it's important to define exactly what an eating disorder is. According to the Mayo Clinic, an eating disorder is a serious condition related to persistent eating behaviors that negatively impact one's health, emotions, and ability to function in important areas of life. A study done by Thompson, Bossiou, and Satir showed that the most common eating disorders are anorexia nervosa, bulimia nervosa, and binge eating disorder. In my presentation today, I'm going to be focusing on anorexia nervosa. I'd like to give you a brief history of anorexia and the development of the disorder in diagnostic terms. The first known case of anorexia was documented by Richard Morton in 1689. He called it nervous consumption. Prior to this, cases with symptoms similar to that of anorexia nervosa were usually found in the context of religious traditions or beliefs. Other clinical problems similar to anorexia nervosa arose, but they were a little different. In 1874, Sir William Gull in England and Charles Lassague in France coined the term anorexia nervosa, or anorexia hysterique. It wasn't until this time that theories related to the etiology and treatment began to emerge. Both Gull and Lassague believed that families likely contributed to this disorder. Another researcher, Jean Martin Charcot, directly blamed families. Charcot advocated for complete separation from individuals' families as a means of treatment. Thus, treatment for anorexia nervosa from the late 19th century to the present has typically consisted of hospitalization and long separations from one's family members, while exclusively being treated by professionals. For a long time, psychoanalytic approaches and researchers in treatment believed that individuals who suffer from anorexia suffer from a variety of unconscious problems like pregnancy fears, primary narcissism, and confusion between body and emotion. A woman named Hilde Bruch conceptualized anorexia nervosa as a disorder of suppression and neglect in childhood, leading to food refusal and the formation of anorexia nervosa symptoms for self-assertion. She advocated for psychodynamic therapy for the patient to promote autonomy and independence from parents and families. It wasn't until a man named Salvador Minuchin pioneered the work of modern-day treatment of anorexia nervosa. He began to implement structural family therapy into treatment programs. He suggested that families could still be important in treatment despite prior practices. Researchers in the Institute of Psychiatry in Maudsley Hospital in London have further advocated for various family and parental treatment programs. An emphasis on using parental skills and family communication skills as a means of disrupting the maintaining behaviors of anorexia nervosa have been increasingly used. Over the past 10 years, a substantial database supporting the inclusion of families during treatment has been developed. I'll be discussing the current treatment methods later on in my presentation, but I did want to touch on a little bit of the history and give you a feel for where we've been as far as treatment goes with anorexia nervosa. The DSM-5 criteria for the anorexia nervosa diagnosis includes the following: restriction of energy intake to low body weight, fear of gaining weight or behavior that interferes with weight gain, and self-evaluation unduly influenced by weight and body shape. Anorexia during adolescence looks a little bit different than it does during adulthood. Symptoms may be expressed differently as compared to adults. Depending on where the individual is developmentally, children and adolescents may be lacking the full ability to verbalize abstract thoughts. They are also less likely to binge and purge as compared to adults. Teens tend to deny body image problems and make health-related excuses for disordered eating habits. This goes back to their inability to think in complete abstract terms. We know this is a huge part of adolescent development, but depending on where they are, they may or may not have developed this skill quite yet to its full extent. And so they may not understand their behavior or the full ramifications of it. They may make excuses for the behavior, like, I'm just trying to eat healthy, I'm trying to cut out fatty foods, I'm trying to exercise, and they'll continue to justify their behavior and normalize it because of their lack of understanding here. Behaviors such as food refusal with teens leads to malnutrition, common in anorexia, but it's actually oftentimes a manifest of nonverbal representations and emotional experiences. The epidemiology of anorexia among adolescents is complicated, and it's deeply disturbing. According to the National Association of Anorexia Nervosa and Associated Disorders, anorexia is now the third most common chronic illness among adolescents. Over 1/2 of girls and nearly 1/3 of teenage boys are said to use unhealthy weight control behaviors. Male adolescents make up about 10 to 15% of the anorexic population. Female adolescents overall have a 1 to 2% chance of being diagnosed with the disorder. As you can see, anorexia is definitely most common in young women versus males, but the statistics for both are on the rise. We can see that right here. Conscien Health cited a recent study published in Pediatrics showing a nearly 6-fold increase over 6 years in serious eating disorders. This trend has caused for great concern among parents and researchers. You can see that from 2005 to 2010, there's a consistent trend in increase with eating disorders among men and women. The etiology and risk factors associated with anorexia nervosa are as follows. They are biological. This could include one's genetic susceptibility. They're psychological. Individuals with anorexia nervosa are actually oftentimes seen to exhibit other psychological problems or abnormalities before diagnosis that actually may contribute to the onset of the disorder. Some risk factors can be environmental or cultural. The environment can play a huge role in one's beliefs, customs, and ideas of what the ideal body or eating exercise habits are. There are also sociological risk factors. We can see this in peers and family. We can see it in the media. We see this with magazine covers, with dance classes and gymnastics classes, pushing girls to conform and to try to reach a certain idealized or picture perfect body type that sometimes is unattainable or unrealistic. We also see temperament and personality type or cognitive processes as additional risk or associative factors with the onset of anorexia nervosa. The most common kinds of treatment for anorexia are psychotherapy interventions, most popularly being cognitive behavioral therapy and psychoactive medication. The greatest results seen have been with individuals receiving psychotherapy interventions or cognitive behavioral therapy, sometimes accompanied by medication. Medication is pretty tricky, and individuals are usually, the hope is to wean them off of the medication eventually if possible. But overall, the best effects are seen with the presence of psychotherapy interventions or cognitive behavioral therapy. The adoption of family approach in treatment has also been a huge factor in the improvement and in the progression of therapy and treatment for anorexia nervosa. Since family therapy has been adopted, we've seen much better results. You can take a teen out of the home and hospitalize them or put them into a treatment program. But eventually they have to go home. And if you're not targeting the problems at home, whether they be parenting, communication, or among siblings, the chance for relapse is much greater because you're not getting to the possible root of the problem. It's important for all family members to be involved, as this really needs to be a team approach. It's not something that a teen or an individual can always handle on their own, and there may be a lot of other factors contributing to it, including the family and their dynamics. And so this has been a huge development in treatment for anorexia. This concludes my presentation on anorexia nervosa in adolescents. I would just like to say that as parents, educators, or a community in general, I hope we can all be more aware of the risks and the warning signs of anorexia or other eating disorders, and that we can try to protect our teens and our children as best as possible from this horrible disorder. Thank you.